The following podcast is part of a certified educational activity. Access the entire activity and complete the post test at peerview.com/GKC860. Downloadable slides and practice aids are also available.
Hello, welcome everyone to this program about navigating the complexities of biomarker testing in the expanding field of precision immuno-oncology. In this program, we'll have three speakers that will touch on different topics. The first of which is myself. I'm Kurt Chalper, a pathologist from Yale University. We will also include Dr. Sanjay Mukhopadhyay from Cleveland Clinic and Dr. Sandeep Patel, a medical oncologist from UC San Diego. So without further ado, I would like to introduce Dr. Sandeep Patel. He's a medical oncologist, associate professor at UC San Diego, and he has a broad expertise in this field. So please, Sandeep.
Thank you so much. And so to take a step back, when we're talking about cancer immunotherapy, and in particular immune checkpoint blockade, we're really talking about giving the right medicines to the right patients so they can release the brake of their immune system, so that immune system will go and attack their cancer. And this has the potential to convert patients who have metastatic disease, who otherwise may have survivals measured in the weeks to months, to patients who actually can live for years now, even with metastatic disease, and sometimes even be functionally cured of their cancer. To date, there are two main immune checkpoint blockade axes, the CTLA-4 axis and the PD-1 axis that you see here. And I think the key distinction we want to make is that both of these are present on T cells as well as other immune cells, though it currently is felt that the effector T cell component of the activity of these drugs is what makes them work. And that CTLA-4 inhibition tends to activate a wider repertoire of T cells within the lymph nodes, while PD-1, Pdl-1 inhibitors tend to work more on T cells within the tumor microenvironment. Now, a key point is sometimes these drugs are used in combination, and we can get toxicities from the utilization of these agents that involve normal organ inflammation, what we call immune-related adverse events. But I think a key point to make about these immunotherapies that are currently FDA approved is these are monoclonal antibodies. These are IV infusions of drugs. But these are actually prodrugs, right? The real target of these drugs, the real drug, is the patient's own immune system. And so the biomarker story that we're going to be talking about today is key in understanding why these drugs may or may not work in a given scenario, in the sense that these are different than the other monoclonal antibodies or other cancer therapies that we use that directly target the tumor with a direct anti-tumor effect. Here, these are prodrugs that activate the patient's own immune system to fight the cancer. And so there are a variety of these agents targeting the PD-1 and Pdl-1 axes, as well as ipilimumab, which targets the CTLA-4 axis. And we see a variety of different therapeutic combinations below, which are FDA approved and standard of care in a variety of different malignancies, some of which we'll cover today. And there are many cancer types that are treated with immune checkpoint blockade, melanoma being the first tumor type in which we had demonstrated activity for these agents, but rare tumor types such as Merkel cell carcinoma, anal cancers, ranging to subtypes of cancer such as triple-negative breast cancer and lung cancer. And so really many organ types can generate cancers that are immunogenic and can respond to immune checkpoint blockade. I'll be highlighting some of these today. In addition to differences in terms of immune response across different histologies, which underlies the biomarker story that I'll be discussing today, we also see that there are different clinical contexts in which these drugs may be efficacious. In particular with immunotherapy, there's certain settings in which the biomarkers drive utilization of the drug, and there's certain settings in which they're suggested, meaning they indicate we may have potential benefit but are not required in terms of treatment of that patient. And as with many drugs, we initially started with drug discovery in the relapse metastatic setting, but moved these drugs into earlier lines of therapy in those diseases in which they'd be more efficacious. And in now many standard of care settings, in fact, at least for melanoma, lung cancer, and increasingly other tumor types, we're starting to see immunotherapy utilized in the localized setting and even the neoadjuvant setting before patients undergo surgery. And so we see a variety of immune checkpoint inhibitor approvals and a myriad of biomarker testing requirements. We're going to talk about these throughout today's session, but broadly when we're looking at Pdl-1 expression, we see, depending on if we're talking about pembrolizumab, atezolizumab, or nivolumab-based therapy, that we're measuring Pdl-1, and we'll talk about what that means momentarily. But broadly, there's different ways. There are different clones, some numeric like 28.8 and 22C3 on the DACO-based platform. Others like SP142, SP263 on the Ventana-based platform. And depending on which clinical context, meaning the line of therapy and the disease you're treating, you use a different clone potentially. But you also calculate a different score, and I think this is key because it's not one size fits all. And so, for example, for pembrolizumab, which has approval in non-small cell lung cancer, you'll calculate a TPS, a tumor proportion score, greater than 50%, for example, for frontline use of pembrolizumab alone potentially, or even greater than 1% in some contexts. But if you're looking at small cell lung cancer, head and neck cancer, cervical cancer, you're using the same clone, a 22C3, but you're calculating a combined proportion score, scoring Pdl-1 on tumor cells as well as immune cells, and we'll talk more about this later. If you're using atezolizumab in triple-negative breast cancer, bladder cancer, or lung cancer, you're looking both at TC staining, tumor cell staining, and IC staining, immune cell staining, with slightly different cutoffs and percentages using an SP142 clone. And then finally, if you're using nivolumab in combination with ipilimumab in non-small cell lung cancer as a pure IO-IO combination, you're looking at tumor cell expression greater than 1% of 28.8. And so this is important to keep track of because this has clinical meaning in terms of matching the right assay for the right patient in terms of the right immunotherapeutic need in terms of their treatment. And so let's start with non-small cell lung cancer. This is an area that has transformed in terms of the clinical landscape due to the advent of precision oncology, which focuses not only on targeted therapies, but immuno-oncology agents as well. And so we look at the frontline setting, and the key here is to rule out driver mutations, meaning EGFR mutations, ALK rearrangements, and so on. If you look for monotherapy options, we see pembrolizumab for Pdl-1 greater than 1%, TPS, tumor proportion score, though many only rely on pembrolizumab monotherapy for TPS greater than 50% based on the KEYNOTE-24 data, or atezolizumab for a Pdl-1 tumor cell score of 50% or immune cell score greater than 10%. We see multiple combinations here of IO-IO, chemo-IO, angiogenesis-IO with chemotherapy here, but broadly we have multiple clinical options for our patients with non-small cell lung cancer, and this has transformed this disease. But to take a step back, it's important to understand that one of the key biomarkers for use of immunotherapy in non-small cell lung cancer is actually next-generation sequencing, not because it tells you something, but it tells you what to avoid. So for a patient with an EGFR mutation or an ALK rearrangement, it would be inappropriate to give them immunotherapy as their initial therapy based on our understanding of the biology of these tumors as well as the clinical trials. There are other driver mutations for which targeted therapy is preferred over immunotherapy, but for EGFR and ALK, we know this in terms of the design of the clinical trial. The other point I want to make, and I highlight this in the lower row, is that when you look at Pdl-1 staining, which often comes back sooner compared to next-generation sequencing, you can have Pdl-1 scores greater than 50% in 60% of ROS1 patients, 40% of ALK patients, 29% of EGFR patients. These are patients who their best therapy is targeted therapy. And so you get a red herring when you get a Pdl-1 score greater than 50%. And I've seen numerous times in my own clinic, the Pdl-1 score comes back the next day because it's an IHC. The next generation sequencing may take 2-3 weeks to return. The patient gets started on pembrolizumab or let's say atezolizumab, and then we find out later they had an EGFR mutation. And this is problematic for multiple reasons. One is that we're giving them a less effective therapy than if we had just waited. And the second is if you try to introduce an EGFR inhibitor, for example, for patients who've received immunotherapy first, they have an increased risk of immune pneumonitis, which is a potentially fatal side effect. And so this is really a scenario in which we need to test and not guess, and measuring twice and cutting once in terms of utilizing immunotherapy is key. And clinically, we'll often give chemotherapy alone while the next generation sequencing is pending before we add an immunologic to avoid this scenario. And so the key is to do no harm. And in such a vein, our goal is to make sure not to overreact just a single Pdl-1 score without fully assessing the actionable molecular drivers a patient may have for metastatic non-squamous non-small cell lung cancer. We see here KEYNOTE-42, which is a study of pembrolizumab for greater than 1%. Pdl-1, where most of the benefit we see in the top left quadrant is driven by pembrolizumab monotherapy for the greater than 50% combination, greater than 50% patients. We see here that patients with greater than 1% here in the bottom left-hand corner seem to benefit, but that's really driven by the greater than 50% population. We see here in the bottom right, the 1 to 49% patients don't do as well. And so in clinic, the main cutoff that we utilize for frontline utilization of pembrolizumab monotherapy is a TPS score, tumor proportion score by 22C3 of greater than 50%. We see here if you try to combine chemotherapy with immunotherapy, regardless of Pdl-1 status, including Pdl-1 0, that these patients have a benefit to chemotherapy plus pembrolizumab for non-squamous non-small cell lung cancer. In this study, it's a combination of carboplatin, pemetrexed, and pembrolizumab versus chemotherapy alone. And we look at Keynote 407, which is the squamous version, frontline metastatic non-small cell lung cancer. We see both a progression-free survival as well as an overall survival benefit, irrespective of Pdl-1 status. And so when you combine chemotherapy with immunotherapy, the Pdl-1 status becomes less important, but if you want an opportunity in the frontline metastatic setting for non-small cell lung cancer to utilize immunotherapy alone, a TPS score by 22C3 of greater than 50% is your gateway into utilizing pembrolizumab monotherapy, though chemotherapy plus pembrolizumab would be an appropriate therapeutic option here, as well as chemotherapy plus bevacizumab, atezolizumab, or chemotherapy, nivolumab, ipilimumab, or nivolumab plus ipilimumab. So multiple options here. The IMpower 110 study looked at atezolizumab for tumor cell 3 or immune cell 3 SP142 high expressors, and similarly to the Keynote 24 study, though this looks at immune cell expression as well, we see an overall survival benefit to those patients that received atezolizumab over chemotherapy alone. The Checkmate 227 study looked in frontline non-small cell lung cancer at ipilimumab plus nivolumab versus chemotherapy, and we see for the greater than 1% cohort a survival advantage versus chemotherapy alone, with some durability with survival data out to 3 years. When we look at an exploratory analysis of Pdl-1 less than 1%, as we see on the right-hand side, this is not the FDA-approved label for this combination, though this is in the US on the NCCN guideline. You can see sustained response and durability with an IO-IO combination of nivolumab and ipilimumab, with 34% of patients living out to 3 years, similarly to the greater than 1% population we see on the left. And so one of the key points is if you find these patients based on Pdl-1 strata, there is the potential for durable responses. But above and beyond lung cancer, what are other tumor types that can benefit that require biomarker-based testing? As I mentioned, melanoma was the harbinger of the efficacy of these agents. However, no biomarkers required for the treatment of those patients. What about these other epithelial-type histologies in which the biomarker story is key in making sure the right drug gets to the right patient? And so when we look at the IMpassion study, this is atezolizumab plus nab-paclitaxel versus nab-paclitaxel alone. We saw a modest survival benefit in the Pdl-1 population based on immune cell staining. This was the SP142 assay. However, a recent update to the IMpassion 131 pivotal study did not meet significance for the primary endpoint of progression-free survival in this same population. And so the question of how best to integrate immunologics in triple-negative breast cancer remains one that's vexing. The Keynote 355 story, it looked at patients with locally recurrent unresectable or metastatic tumors who express Pdl-1. This is a 22C3 assay, CPS greater than 10%. And we see here in the progression-free survival a hint of signal similar to what we saw, and that this really was driven by the CPS greater than 10% story. However, the overall survival remains to be seen in terms of many of these studies, in terms of the formal publication, so we can delve into many of the nuances of potential benefit. Moving on to some GI cancers, we see esophageal and gastric cancer. And the Keynote 181 study looked at 22C expression, combined proportion score, tumor and immune cell scoring in gastric cancer. And for patients that had CPS greater than 10, these patients had benefit with pembrolizumab monotherapy versus chemotherapy alone, with a particular signal of interest in CPS greater than 10, but also squamous cell biology. The Attraction 3 study looked at nivolumab versus chemotherapy in an unresectable advanced population of metastatic esophageal cancer after prior chemotherapy, and this is regardless of Pdl-1 status. And so we see across multiple tumor types, here focusing on the GI tumors, we see the Checkmate 649 study looking at nivolumab plus chemotherapy versus chemotherapy alone in the frontline setting, has recently met both endpoints with overall survival at a pre-specified interim analysis. The Checkmate 577 study looking at nivolumab plus placebo versus placebo as adjuvant therapy following neoadjuvant chemoradiation, which met its primary endpoint of DFS, and the Keynote 590 study looking at pembrolizumab plus chemotherapy versus chemotherapy alone, which met its primary endpoints of OS and PFS in esophageal cancer. And so the best is yet to come still in many of these histologies, and especially in GI cancers. And so to conclude, immune checkpoint inhibitors work by blocking T-cell inhibitory signals. They remove the brake on the immune system, but the drugs we're giving based on the right biomarker story for a given patient are actually prodrugs. The actual drug is the patient's own immune system, and that's why the biomarkers are so important in terms of personalizing immunotherapy. The cancer immunotherapy landscape is rapidly evolving, and the benefit of immune checkpoint inhibitors is seen across multiple tumor types. We've seen an evolution from the cutaneous malignancies to thoracic malignancies, now increasingly to the gastrointestinal malignancies, and that predictive biomarkers can guide clinical decisions regarding the use of these very important therapeutics, which can have substantial efficacy even in patients with historically incurable disease. In non-small cell lung cancer, the most important test remains next-generation sequencing to look for therapeutically targetable genomic alterations, but it's equally important in terms of immunotherapy to make sure we avoid giving patients with targetable driver mutations immunotherapy when targeted therapy may be their most effective choice. Pdl-1 expression is also important for patients with TPS scores greater than 50%. Pembrolizumab monotherapy remains an option for these patients based on the Keynote 24 story. And Pdl-1 expression also, in terms of IHC, has a role in multiple other tumor types. So Dr. Mukhopadhyay will be talking about this momentarily. And microsatellite instability and recently TMB based on the Keynote 158 study are also FDA-approved immunotherapy biomarkers, and Dr. Shalper will be discussing these momentarily. And so with that, I'd like to introduce Dr. Mukhopadhyay, a pathologist at Cleveland Clinic, who will be discussing immuno-oncology biomarkers in current clinical practice.
Thank you so much, Sandeep. This was a great talk. I always take away something useful from your talk, so really appreciate it. I'm going to talk about the more practical, day-to-day things that pathologists face when interpreting Pdl-1 immunohistochemistry in day-to-day life. So we're going to start with just the basics that I think most of you would be familiar with, and that is surveilling T cells and Pdl-1 expression. And essentially the idea here is that CD8 positive T cell infiltrates secrete various cytokines, including most significantly interferon gamma, and that causes tumor Pdl-1 expression in some tumors, which then enables this kind of interaction between the Pdl-1 expressing tumor cells and the CD8 positive T cell infiltrates via PD-1 engagement. Now, what's important to recognize is that there are several immune checkpoint inhibitors. Each one is paired to a different Pdl-1 assay, and so the context is different across tumors. We have highlighted here the difference between complementary and companion diagnostics. It's very important to understand here the difference between a companion diagnostic and a complementary diagnostic. So to simplify it to its very basic level, a companion diagnostic is something that is mandatory for the use of that particular drug, whereas a complementary diagnostic is recommended but not mandatory. So as you can see here, there are three companion diagnostics. One is the 28-8 IHC assay for the Nivo-AP combination. There's the 22C3 that Dr. Patel mentioned for pembrolizumab, and then there's the SP142 for atezolizumab. Now, in addition to this, we have Pdl-1 testing requirements in non-small cell lung carcinoma. So for example, in the pembrolizumab drug is an anti-PD-1 therapy. It requires the immunohistochemical assay, which is 22C3, and the indications there are both first-line therapy, as Dr. Patel mentioned, as well as second-line therapy as monotherapy. And there the tumor proportion score is required to be at least 1%, so 1% or more although the 50% cutoff is also significant, as Dr. Patel mentioned before. In contrast, the Nivo-Ipi combination is tied to the 28-8 immunohistochemical assay. This is a companion diagnostic, and SP142 is for atezolizumab, as we mentioned before. The TPS and tumor cell expression are used in the 28-8 and 22C3 assays, whereas the SP142 is again an outlier because it uses immune cells, which again introduces some degree of inter-observer reproducibility problems and complexities in terms of reading this assay. So the tumor proportion score, which is used in 22C3, is essentially, to simplify it very much, the tumor proportion score is essentially asking the pathologist what percent of the tumor cells are positive with this particular assay. So we exclude cytoplasmic staining, we exclude immune cells, we exclude normal cells. The only thing we count is tumor cells. So I really like this system. For whatever its limitations are, the virtue of this system is simplicity and ease of applicability in daily practice, and we'll go over that. So the couple of things to look out for in this scoring system is, the first principle is only membrane staining is positive. So if you have cytoplasmic staining, for example, without membrane staining, that wouldn't be considered positive. It has to be membrane. And the kind of staining you see is shown here. So on the left hand side is a non-small cell lung carcinoma. You can see the abundant cytoplasm and prominent nucleoli. And the right hand side shows you crisp, clear membrane staining, the kind you would see in, for example, in a HER2 positive case, and that's very easy to interpret. The second principle is, at least in non-small cell lung carcinoma, count only tumor cells and not inflammatory cells. Again, that makes it very easily applicable in practice, because tumor cells are usually easy to identify, and the complicating factor of counting lymphocytes and macrophages is not applicable with the 22C3 assay and non-small cell lung cancer. The third factor, which is actually a pitfall and is really the only major pitfall with 22C3, is that macrophages are positive for Pdl-1, and therefore in this particular assay we do not count macrophages. In this picture, the Pdl-1 positive macrophages are shown on the left hand side, and an corresponding H&E is shown on the right. So you should be aware of this pitfall if you are tasked with interpreting the 22C3 assay. Sometimes you will see tumor and macrophages in the same field, and in this picture on the left hand side, which is Pdl-1 22C3, the tumor cells are at top left. You can see the cells are larger. Even on the immunostain, you can see that the tumor cells are larger, the staining is stronger, and on the bottom right of the same picture are the macrophages, and of course those cells are smaller and the staining is a little bit less strong, and the corresponding H&E is seen on the right hand side. So this can be a problem. So there is some need for morphologic skill in interpreting cases where admixed macrophages are present. Here's an example of where you could go wrong with macrophages present within a tumor. So if you were going quickly and you didn't pay attention, you might say, well, there is some Pdl-1 positivity in this tumor. You can see some cells that are clearly showing membrane staining. However, you would be wrong if you scored this case as Pdl-1 positive, because the positive cells, as highlighted by the arrow, are actually macrophages. So they should not be counted. And in fact, the cells that are tumor cells highlighted by the arrowhead are actually, all of them are negative. So this is a case that should be scored as 0%, and the positive cells should not be counted at all. Finally, any intensity of staining is positive in Pdl-1, so it doesn't matter, as opposed to, for example, HER2 staining, it doesn't matter whether it's weak or moderate or strong, all of it is considered positive. So the picture on the left with strong staining is positive, the picture on the right with weak to moderate staining is also positive, since both of them are membrane. The intensity can of course vary within the same tumor. This is why we have proportion scores, because within the same tumor, some cells can be positive and some can be negative. Also, some cells can be strongly positive and some can be moderately or weakly positive. So in this picture, the top right of the field is strongly positive, whereas the left hand side of the field shows less strong or moderate staining. So the correct score in this case would be 100%. Finally, how do you report these cases? Our approach is to make the scoring as simple as possible. So what we report is the exact percentage of tumor cells that are Pdl-1 positive. And I'll show you an example here. So there are two examples. The first one is for a 100% positive case. So we would say Pdl-1 clone 22C3, The second line says 100%, and the comment you can say things like, the specimen is inadequate or whatever else you would like to say about the interpretation. The second example shows you a case in which the tumor cells positive are 1%, so all we say is 22C3, 1%, and leave it at that. I would like to mention that I've often seen that giving a precise number is better than giving a range. I think ranges create problem for oncologists. So if you say something like less than 50% or 1 to 10%, most oncologists would not be happy with that kind of thing. A general sort of an approximation of an exact number is better than giving a wider range in practice. So to summarize the Pdl-1 22C3, tumor membrane staining of any intensity counts, beware of macrophages, and report percentage of positive tumor cells in your pathology reports. In terms of SP142, I will not go into much detail other than saying that anything above 1% is considered positive in this scoring system, and importantly it uses both immune cells and tumor cells, and so it is actually a very complicated scoring system compared to the 22C3 method. It's used in both triple negative breast cancers and bladder cancers, and this is one that I don't do personally in my practice because our breast pathologists do this, but it is actually a pretty involved and difficult system to use compared to the 22C3 system. Again, I'm not going to go into much detail here, but the top panel, so the top 3 pictures show you an example of a negative Pdl-1 expression by the SP142 immune cell scoring system, and the bottom 3 pictures show you what would be considered positive, that is 1% or more, and there are various immune cell patterns including single cell spread and aggregate staining. The 22C3 assay is also used in bladder cancers and G-junction tumors, as Dr. Patel mentioned, and cervical and head and neck squamous cell cancers. The difference here is you use a CPS system in which again both tumor cells and lymphocytes and macrophages are used. So again, the CPS is different than the TPS in that it uses immune cells, and therefore the scoring system gets considerably more complicated because of the incorporation of immune cells. This diagram shows you a particular example of how this scoring system is used. It shows you tumor cells as well as immune cells, and what happens if tumor cells are only presented in a particular area, the positive tumor cells. So there are a formulae for that which you can use. Again, the principle is the same, is that either tumor or immune cells can be scored. I'd like to quickly draw attention to the Blueprint 2 study, and the point of this study was to look at whether these various clones are comparable, whether a tumor positive by one clone would also be positive by another clone. And to summarize the results of the study, the 22C3 was indeed comparable to 28.8, to SP263 and 7310. The outlier really was the SP142 clone, which we have already mentioned. In this particular picture, it shows you that all the other clones are positive, but the SP142 is negative. So it was certainly an outlier. And the graph on the right hand side also shows you, when you look at the aggregate of all the cases, you can see that the SP142, which is the blue line, is actually the outlier in this study. It's the one that does not correlate with the rest of the clones. And the summary of this concordance between pathologists is that there was a high degree of concordance between 0.81 and 0.91 in terms of tumor scoring, and low concordance in terms of stromal cell scoring from 0.17 to 0.36, which very much reflects what we see in real life and in daily practice. It's much more concordant if you just look at tumor, and much less concordant if you're looking at other cells. In terms of sample adequacy, the one thing that I would like to mention is the one thing in our practice that comes up that would make us reject a particular sample, that we would say that this is not adequate for Pdl-1 scoring, is the number of tumor cells. So if you have only 2 or 3 tumor cells, that is not adequate for Pdl-1 scoring. So the number that we use is 100. If you have 100 tumor cells, then that is adequate for Pdl-1 scoring. Anything less than that is essentially rejected. And that's the message that I would like to leave you with, is that 100 tumor cells is really the key number to be looking out for, but there are several other indications also for what we would consider an optimal sample for Pdl-1 testing. And with that, I'd like to hand it over to Dr. Kurt Schalper, who is at the Yale School of Medicine, for the third part of our talk. Kurt, take it away.
Thank you. So in the last part of the presentation, we'll discuss molecular biomarkers, including tumor mutational burden and microsatellite instability. So if we look at the landscape of immunotherapy-related biomarkers, there have been a lot of efforts to try to identify metrics that can predict sensitivity and resistance. Some of these metrics reflect properties more of the immune system, what I call phenotypic markers, which are indicated on the upper side of the slide, which include things like Pdl-1, tumor-infiltrating lymphocytes, or RNA signators reflecting those inflammatory responses. And there are a few other things that are under development that are indicated there. In the bottom part, we can see what I call genomic or tumor-related metrics, which are generally related with DNA-related phenomena and include things like microsatellite instability, tumor mutational burden, and discrete gene mutations shown to be associated with this clinical behavior. If we look at the whole landscape, today we have 3 biomarkers from this picture that have been regulatory approved by the FDA. One that belongs more to the immune-related biomarkers, which is Pdl-1, Immunohistochemistry, we just saw. And then we have 2 markers that have become approved from the more tumor genomic side, which are microsatellite instability and tumor mutational burden. The most important point here is that as we move on, we expect more biomarkers to become approved and move from the research and into the clinical scale. So the first biomarker we'll discuss is microsatellite instability or mismatch repair deficiency testing, which essentially include those tumors that have problems repairing DNA, particularly mononucleotide repeats, and they tend to accumulate mutations in these microsatellite sequences, which are short mononucleotide repeats that are across the whole genome. So today, the indications associated with this biomarker include in this solid tumor, generally as a second-line indication, and then colorectal cancer as a front-line indication. And then we have approval also for combination therapy, including PD-1 and CTLA-4 blockade, that it's also, in this case, restricted to colorectal cancer that have progressed on frontline treatment. We actually have seen progress in the field, and this expected that some of these indications may actually be expanded or changed. One of the data that support and actually move some of these approvals forward was produced by Luis Diaz group when they compared tumors with mismatch repair deficiency relative to tumors that were mismatch repair proficient or microsatellite stable. Now we generally call them MSS. And what they saw was a profound effect of immunotherapy characterized by prominent and durable responses in this population that are reflected on a higher response rate, which are on the right side on the slide, and then longer survival. What was very striking about the studies is that the benefit was seemed to be associated with the molecular phenotype more than the tumor indication. And you can see there in the chart that multiple tumor types with different biologies and different anatomic locations show a comparable sensitivity to immune checkpoint blockers. One important question when we think about this problem is how to test, how to implement this clinically, and what type of tumors should actually be tested and when. And one interesting study looked at a number of different tumor types, in this case 18 different tumor types, and look at a large number of loci to identify this microsatellite instability phenotype. And what they found using this algorithm was that the highest frequency of microsatellite instability includes colorectal tumors, uterine carcinomas, and gastric malignancies, with frequencies that range between 15 and 25%. What was interesting is that there is a long tail of different tumors that have very low frequency of microsatellite instability, but they all have some, which actually brings up the question of what tumor type should be tested up front, or we should test everyone like we do for some other biomarkers. What the other interesting finding from the study, looking again at the large number, in this case more than 200,000 microsatellite loci, is that the apparent distribution and frequency of individual microsatellites affected in different tumor types is different. And this brings up the question of using cut points that may be different across indications, as we have seen before for things like Pdl-1 and other contexts. So I think we have a lot to learn on how to apply microsatellite instability testing in the clinic. A frequent question relative to this biomarker is what is the best way of testing it. And so far, there have been extensively validated methods that are available in most academic pathology centers, which are immunohistochemistry, which generally includes four markers that are indicated there: MLH1, MSH2, MSH6, and PMS2. And the way that this works is trying to detect the absence of the protein in tumor cells. And I will go back to this point in the next few slides. The most important point is that this is a very simple test. It works on a very well-known platform, which is immunohistochemistry. And it also has a rapid turnaround and low expense. So it's actually a very practical way of initiating the testing. The important point is that the immunohistochemistry detects the defects proper in the absence of these mismatch repair proteins. Another method that is widely available to test for this marker is what we call the molecular or PCR-based test, which essentially doesn't test the defect, but tests the consequences of the defect, which are essentially the accumulation of microsatellite unstable loci within the sample relative to the germline of the same patient. And you can see there an example where we typically measure 5 mononucleotide markers, and we see the change in the size of those mononucleotide markers as an indication of microsatellite instability. One important point relative to the decision of what method to test relies on the expertise and the availability of the center testing, but also on the fact that to date, most of the approvals and the clinical trials that have show benefit of this biomarker positive population have used these two methods. So despite the fact that there are a number of next generation sequencing algorithms being developed or reported within panel tests, I think to date we know that the benefit has been demonstrated with these two methods. Another consideration relative to the method selection has to do with the availability of specimen, because as opposed to immunohistochemistry that only requires a single 5-micron section of tissue, tumor tissue, the molecular test also requires germline DNA to be able to do a comparative analysis. So sometimes when there is only tumor tissue available, there is not really much option to do the molecular test. So all of these variables are weighted and leveraged to decide what is the optimal testing method. There are reports supporting also that the molecular test has a slightly higher sensitivity, but generally the concordance between the methods is high. This is an example of a prototypical normal or microsatellite stable case. This is a colorectal tumor where you can see positivity for the 4 markers both in tumor cells and in non-tumor stromal cells. This is very important because we generally use non-tumor tissue within the slide as an internal positive control to be able to rule out technical issues with the staining. But this is the majority of cases that we see that essentially have no absence of repair proteins. This is another example of a prototypical microsatellite unstable case in which we can see clearly that 2 out of the 4 proteins, in this case MLH1 and PMS2, are absent in the nuclei of tumor cells, but they're present in the normal stromal cells, the majority of which are lymphocytes. And then you can see that the other proteins are present, which is consistent with a phenotype of microsatellite instability due to the absence, in this case, the heterodimer MLH1 and PMS2. I put this example because this is a common scenario. However, because no test is perfect, there are some cases that are ambiguous or they're somewhere in between. And this is an example of one such tumor where you can see that the absence or positivity for, in this case, MLH1 is focal. And it's actually very hard to say if it's positive or not in the stroma. So this is the kind of case where we would say, you know what, it's somehow downregulated in the tumor, but some cells are positive, and we don't really have a perfect stromal control. So these cases happen infrequently, but there are there. And one important point is to first try to address if the sample may have a problem, and this could drive multiple markers to have inconsistent staining. But another frequent solution to this is actually to do the molecular test to verify if this case has actually a mismatch repair deficiency phenotype or not. So again, this is an example of what is the possible outcome. So now we're going to switch gears to discuss the last molecular marker of this session, which is the tumor mutational burden, or TMB, which is essentially the number of non-synonymous mutations obtained in a particular amount of genomic sequencing. And it can be expressed in multiple ways. Generally, we talk about number of mutations when we talk about exons, or number of mutations per amount of genome sequence, usually in megabases. So as opposed to last year, in June, very recently, there was a approval for a tumor mutational burden to be used in second-line treatment in multiple solid tumors. And this is actually very impactful because there has been discussion in the community on how robust and validated is this biomarker. As you can see here in the slide, the approval in this case was based on Keynote 158, which is a multi-tumor clinical trial. And actually, the approval of the biomarker was particularly for this Foundation 1 complementary diagnostic with a cut point of 10 mutations per megabase. So the effect of tumor mutational burden has been seen in different studies, and this is an example of the first report by Alex Snyder, where they demonstrated that tumors, in this case melanomas, with a high number of baseline non-synonymous mutations, or high TMB, derive higher benefit by blocking, in this case, CTLA-4 using ipilimumab. The results from this study were then expanded to the use of Pdl-1 blockers, and this is a study by Nair Rizvi and collaborators at Sloan Kettering, where they look at the cohorts of patients with non-small cell lung cancer treated with pembrolizumab. And what they found was, again, that those tumors with high number of non-synonymous mutations did better, they respond more, and then they had a survival benefit. Different studies have validated this in multiple settings, but one interesting finding from, in this case, one pooled analysis from the Genentech group was that the amount of mutations seemed to have an incremental relationship with outcomes. So the implications of that is that different cut points may provide different benefit. And you can see here in the slide that the highest the cut point used for tumor mutational burden, the lowest the hazard ratio, meaning that there was a higher benefit. One interesting breakpoint relative to the distribution of markers was around 16 to 18 mutations per megabase, where about a third of cases were positive in lung cancer, and they had a significant impact of about 30% reduction in risk of death. So essentially, there is a relationship here between the cut point and the benefit that can be obtained. And there are also questions relative to the possibility of this tumor mutational burden biomarker to be used to also support combination therapy. And this is an early retrospective study from Keynote 189 that combined chemotherapy with pembrolizumab, showing a potential advantage or benefit in patients that had different tumor mutational burden. One important question from the, particularly for the diagnostic community, is what is the right way or the best way to test for tumor mutational burden? And today there is actually one approved assay, but a lot of questions were relative to what are opportunities for different labs to test this metric. And this slide summarizes what are sort of prototypical tests, the gold standard, which is whole exome sequencing, which is a sequencing essentially of all the coding regions of a gene. It's a very complex assay with difficult interpretation and not very widely available, but it's at this point the reference of the number of mutations that can be obtained. And it certainly doesn't have a clinical grade turnaround time at this point. When we contrast this sort of golden standard with the current assays such as Foundation 1 companion diagnostic or Sloan Kettering impact panel, we can see that they have very different amount of sequencing. In this case, they only have a certain amount of genes, and the number of megabases of sequencing is also much smaller, which raises a lot of question of how reproducible and comparable these assays may be. There are also clinical implications relative to the turnaround time and the applicability of this type of assays in the clinical setting. So to address this, there have been international efforts to try to standardize tumor mutational burden and try to see if the different assays, different labs can provide comparable results. So this is a summary of a study recently presented by the Friends of Cancer Research Group that are pioneering a standardization effort. And as you can see in the slide, they essentially distributed data or samples to different labs, in this case 11 to 16 different labs, that analyze either data from TCGA cohorts, cell lines with known levels of mutations, and then a small number of clinical specimens. And what was striking from the result is that while most of the assays and labs show a high correlation, a linear relationship between whole exome sequencing as a reference and their panel or whatever assay they decided to do, the numerical score obtained is actually different. And you can see that very clearly in the highlighted top right chart, where the majority of assays and labs are able to produce a continuous linear score relative to whole exome sequencing, but they all deviate above or below the 45-degree line, which is essentially the slope. So this supports that while many assays and labs have a high correlation, the cut point to decide what is above or below certain tumor mutational burden threshold may differ between labs. So in other words, their assays and labs are not comparable or interchangeable. And this is something that needs to be explored further to determine how to expand the use of tumor mutational burden in the clinic. So to finalize, I would like to bring up what are the future directions and what other things are expected to be resolved or implemented over the next few years. And what I show you is that there are multiple biomarkers being developed, but there is also different ways of using biomarkers that we already know. So the first point I wanted to bring up is refinement of available biomarkers. And one example of that is the use of detection of tumor mutational burden in now circulating tumor DNA. And this has obvious advantages relative to the capacity to test and the non-invasiveness status of that assay. And there have been preliminary data supporting that blood-based tumor mutational burden could report on sensitivity and resistance to treatment. There are other parallel efforts trying to look at RNA signatures, generally looking at T-cell inflammatory responses, and there are at least 4 or 5 RNA signatures being tested. And then also looking at targets beyond Pdl-1 and PD-1 axis, and there are a number of alternative inhibitory checkpoints or receptors that may have potential. The second layer of future directions has to do with the integration of biomarkers that are non-redundant or non-associated. And one example of that is the possibility of integrate Pdl-1 with tumor mutational burden or microsatellite instability. Many studies have shown that the tumors that generally show Pdl-1 expression tend to not show high levels of tumor mutational burden, and that opens up the possibility of selecting patients using more than one biomarker. There is a high redundancy between tumor mutational burden and microsatellite instability, so those two are not seen to be, at this point, compatible for integration. And then finally, there are novel biomarkers being developed, as I show you in the first slide of the third segment, and many of which are related with looking at immune cells, but also different type of immune cells beyond T cells, in this case myeloid cells or other cells from the innate immune system, as well as stromal cells, including fibroblasts and vascular structures. So we expect to have biomarkers developed in that space and also in the metabolic field. And there are also additional patient features that have been studied, and many studies are ongoing trying to see if the germline configuration of the patients, particularly relative to the HLA types, may have a strong association with clinical outcomes. And also there is a whole world of imaging biomarkers being related, particularly with what I call immunoimaging, which has to do with targeting molecules using PET-CT and being able to do a sort of a general view of markers in the whole human body. And this is also actively ongoing. So now, in the last few minutes, we will address questions received from the audience. And the first topic I would like to bring up would be what happens now after approval of tumor mutational burden, and are we there yet to decide how to use, implement, and really generalize the use of this biomarker? So please, I would like both presenters to comment on that.
Yeah, and so I think what we're discussing more specifically is Keynote 158 and the FDA approval for pembrolizumab for tumor mutational burden greater than 10 by the Foundation Medicine CDX. Just a bit about the study. It was a heterogeneous population, but it only included certain tumor types. It was predominantly small cell lung cancer, some cervical endometrial cancer, anal cancers, vulvar cancers, and a couple other tumor types as well. One of the thoughts is with approval for TMB greater than 10, oftentimes these assays, the next generation sequencing assays, are done in, for example, colorectal cancer, breast cancer, and in those tumors types, 0 of those tumors were studied in the Keynote 158 study. And so to say that, a TMB 11, for example, for a colorectal cancer patient would be a strong indication for use of pembrolizumab, I think would be beyond what the data suggested, though the approval is for all comers. I think it does lead to several questions, though. And I think one question is we discussed earlier, and Dr. Schalper, you mentioned this, is how TMB is calculated and how everyone may or may not have their own assay that might have unique ways of calculating TMB, and that as you get closer to 10, those nuances may actually be all that determine whether a patient actually has a TMB of 10 or 11, or maybe 8 or 9, and whether we should even be thinking about this as a binary biomarker when it's quantitative and continuous.
Yeah, so this is a great comment, and I would like to add that there are technical aspects that are very difficult to interpret. One of which is related with what is the minimum amount of sequencing that is necessary to provide a meaningful TMB result. To date, I don't think we have a straight answer to that question. It has been proposed that panels that encompass in the neighborhood of 1.5 to 2 megabases of sequencing are able to have a high concordance with tumor mutational burden. But then there are many questions relative to how should the variant calling be done, what are the best models for that, and then what is the right sample to actually obtain a reliable tumor mutational burden. In other words, what is the minimum amount of tumor content to actually identify an accurate number of mutations. I think as a summary, I would mention that I don't think we have a standardized tumor mutational burden assay. I think the data is emerging. The clinical data is optimistic, and that's probably driving the approval. But I think we have a lot to learn to try to expand the use of this biomarker and exploit the full benefit. It's a difficult point that has to do with the landscape of Pdl-1 assays and what is really currently the right way of putting this in practice. Should we have 4 different Pdl-1 assays in every lab, and should we use 4 different scoring systems for each indication and each specific treatment, or should we try to do LDTs and focalize the assays, or are they interchangeable, at least the ones that we know are comparable in studies? What is the best way around that? So maybe I would like the opinion from both of you again.
Yeah, I think from a clinical context, there were specific clones used, Pdl-1 clones used in specific studies, and as much as possible, we'd like to honor that. But practically, it's not possible for most pathology shops to have 3 different antibody clones, a DACO, Ventana platform, and run them. And so typically, I think we rely on the blueprint data, which suggests that the 22C3 and the 28A from DACO, the SP263 on the Ventana, are all relatively in agreement, and that we can score, whether it's TPS, CPS, TC, IC, we can score based on that. The best analogy I could make for a clinician, and this is very much more nuanced, I'm sure, for the pathologists, is that these are brands of crayons, right? And it turns out, 3 of the brands of crayons the red looks awfully similar, the blue looks awfully similar, and in one of the brands, the colors may sometimes differ to where it may affect the outcome. And so I think in general, at least our institution, for example, we rely on one clone, and we basically cross-extrapolate that to create a TPS, CPS, TC, and IC3 or IC for clinical context.
Yeah, I agree with Sandeep. In terms of the practical scenario for pathologists, what this means is that for big academic labs and for big commercial labs, this is probably feasible to do a separate antibody for each indication, because they have bigger labs, they have more personnel, they can do more involved testing, whether LDT or otherwise. But for smaller labs, this essentially makes it non-viable. It's impossible. It is impossible for a small private lab where there are only 5 pathologists or less to do a separate clone for each one. So in practice, what happens is that these smaller practices end up sending out all their Pdl-1 testing, because that is the only way that they can couple specific Pdl-1 clones to specific treatments. Now, I have one question for you, Sandeep. In terms of the regulatory, the rules, is it allowed to, for example, to use a sp263 instead of a 22C3? Is that permissible within the current framework in companion diagnostics?
Yeah, broadly, when you look at FDA labels, they ask for a tumor proportion score, for example. And they don't necessarily specify in all the labels the specific antibody clone. And that actually makes sense, right, for global approvals in which, especially resource-limited settings, in which they may only have the resources for one platform and one stain, it would be overly restrictive. And so the ability to take an antibody and create let's say a TPS, a CPS, a TC, an IC, I think is very reasonable. Because, the way I like to think about it is, 3 of the 4 different major crayon boxes are pretty darn similar. And the way that the color looks and the way you score is in the eye of the pathologist in terms of how they adjudicate, make sure there are 100 viable cells, avoid macrophage counting, and things like that. And so it is permissible. And in fact, for many jurisdictions, it's really the only path forward.
So let's go to another question from the next pool of questions received. And in this case, we'll touch on one question of high practical value, which is that how and what is the value of testing Pdl-1 in cytology specimens, and what are considerations around that? So maybe Dr. Mukhopadhyay, can you comment on this?
Yes, Kurt. I think that this is really an important practical issue, because some specimens, at least some proportion of specimens is only cytology. So you won't have a core needle biopsy or a corresponding formalin-fixed specimen or a real biopsy on some proportion of cases. So the cytology specimen is really the only specimen available. And there is some work that's published now from Sinchita Roy Chaudhury's group at MD Anderson that shows that by and large, the Pdl-1 scoring, at least for tumor proportion score on cytology, is by and large in line with the scores that are seen in formalin-fixed biopsy specimens. And other groups have also shown. So there are some exceptions where there is some discordance between cytology and corresponding biopsies, but by and large, the scores are the same. So I think it's very practically important, if you want to avoid putting the patient through another procedure, to be able to have Pdl-1 scoring on cytology. I would stress here that it's very important that your Pdl-1 scoring system is validated. And if you're not validated, to send out then possibly your cytology Pdl-1s to a lab where the scoring system has been validated on cytology.
One quick question around that. Would you advise or consider to score immune cells in cytology specimens for Pdl-1?
I would not. No, I think this is, you know how difficult it is, Kurt, to incorporate immune cells even in biopsy specimens. And when you take it out into cytology specimens, I think it gets even harder. So I
completely agree. With that, I think we will close this segment of the discussion points. Thank you.
This activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/GKC860.